Sir, it's live. Please begin.
Hi everyone, good evening. We have a presentation on bipolar disorder today on World Bipolar Day. I am Dr. Rahul Khemani, a consultant psychiatrist practicing here in Borivali in Mumbai at Heart and Mind Clinic, and I'll help you understand more about bipolar disorder. Let's begin with a little introduction on bipolar disorder, and then we'll go into the signs and symptoms of both mania and depression. We'll understand how do we diagnose it, and finally the treatment in in a concise manner, and then we can go into the question and answer rounds. So we'll begin with a few questions first. What type of disorder is a bipolar disorder? It's kind of like a question and answer to begin with. And once we have a flow into the presentation, then I'll start with the theory part of it. So, people, you all can type in your answers. The answer is mood. Yes, those of you who are right have understood that bipolar disorder is also called as a mood disorder. Then, mania involves which one? A. Boundless, frenzied energy. B. Feelings of euphoria. C. Ideas coming too fast and too many. Or D. All of the above. Yes, I know all of you would have answered D, all of the above. Depressed individuals express which of the following symptoms? Behavioral symptoms, physical symptoms, cognitive symptoms, or all of the above? I guess all of you understood that yes, it's going to be all of the above again. In clinical practice, what treatment do we prefer for the management of bipolar disorder? And I guess again, the answer which y'all will understand is mood stabilizers, antipsychotic, antidepressants, and anti anxiety medicines, whichever needed, but practically a bit of all of them. And lastly, which is the preferred mood stabilizer in routine practice? A very tricky question, which I'll be covering at the end of my presentation. Lithium is a beautiful mood stabilizer, as is divalprex, both in their own ways good, but we prefer both depending on the need. So, hey there, we are your host for today, Mania and Depression, and we will be explaining about ourselves a little more in the coming slides. So, bipolar disorder, to understand, is a brain disorder that causes changes in a person's mood, energy, and ability to function. And people with bipolar disorder experience intense emotional states that usually occur during distinct periods of days to weeks, and we call them as mood episodes. This sounds very similar to mood swings. Is this mood swings? No. Mood swings are something that happens on a day to day basis, on a daily basis. Today, maybe in the morning, I was very happy when I woke up, but because my boss scolded me, I am sad. Is this bipolar disorder? No. This is just a mood swing. Um, a female wakes up in the morning and realizes that her periods have started, has a very bad mood, and she's going to continue having that for the next 2 3 days because periods cause a lot of mood swings. Do they have bipolar disorder? No. So, like I said, it is for days to weeks the same mood. So, if I'm happy for consecutively many days. And if I'm sad for many weeks together. And that's why I called as episodes. The prevalence, as we can see, is approximately 6.9%. The male female ratio is equal. Equally, anyone can get it, and the annual incidence is considered to be less than 1%, but we cannot say for sure because the milder episodes are usually missed and those patients don't come to us in the practice. So, welcome. I am Mania, and to diagnose, you need at least three of the following symptoms. Which three? Mania is a word that is derived from ancient Greek, which means frenzy. Frenzy means too much. So, hyperactivity. You cannot sit in one place. You keep moving around. You're very active. You want to do 10 things together. Elevated mood. Your mood is so happy, so excited. Even if the worst things have happened around you, you're still smiling, you're still happy. You are constantly in a very excited mood. And sometimes that excitement can turn into irritation as well. Your speech is too much. You cannot stop talking. It is sometimes, some people say it looks like a pressure cooker. You cannot stop it. You keep speaking constantly, and to stop you is literally next to impossible. Yes, like I said, a lot of irritability. In the irritability, you can sometimes even hit someone, you can give out abuses, you can get so aggressive that you can break things. Then comes a very interesting phenomenon called as grandiose. In grandiosity of mania, you think you are someone very important, very influential. You can feel that you are someone who knows the president of USA. You think you can go and climb Mount Everest. You think you can purchase anything even beyond your capacity. So this feeling is called as grandiosity, where you think you can do literally anything which is impossible for you in that moment. Yes. Then psychosis. Psychosis means sometimes you start having suspiciousness that people want to harm you, people are following you, people are against you, or sometimes you can have certain hallucinations. Hallucinations means you can hear some voices or you can see certain things which are really not there, or someone is not speaking, but you can still experience it. Another interesting concept called as reduced need for sleep. So that does not mean that you don't get sleep. You can sleep if you want to sleep, but your mind in that moment is so hyperactive that it says that it does not want to sleep. So people don't complain that they can't sleep. They say that they don't want to sleep and they want to utilize that extra time for working. Distractibility, yes, you cannot stay focused. So even though you're hyperactive, it does not lead to any productive outcome. It just leads to you being distracted so much that you end up doing nothing, even though you're doing 10 things simultaneously. And lastly, like we discussed, racing thoughts. We call it as excessive, too many thoughts, where we cannot control our thoughts. One idea jumps to the other, which jumps to the other, and it keeps on jumping. And lastly, risky behavior. This is something that I'm highlighting because this is something that is clear and you can identify mania with this. You're driving at a very high speed. You exhibit some promiscuous behavior where you go and have unprotected sex and you're not scared about it. You go and you start doing things which you would never even think of trying before. So, yes, you might drink too much, you might smoke, you might do all the things that you have never been taught or you never spoke about as well. The important part is that all of these symptoms should be there for at least 1 week. It cannot be that you're doing this for one day and then we diagnose it as mania. To diagnose mania, we need all of these things for at least 1 week. And this should be severe enough to cause dysfunction in your work, family, or social activities. So that is why we call it as socio-occupational dysfunction. Because you can have all these things, but you're doing all your work, you're earning for your family is happy, your friends are happy, then it can be a personality and that can be also very normal. So this behavior must represent a change from the person's usual behavior and be clear to friends and family. It should not be that suddenly you've been always like this and now you realize that this is there, so this is mania. No, it has to be there suddenly out of the blue for the last 1 week, where you were very silent, very calm, very hardworking, and suddenly you started behaving in this manner. Let's go to the second part. We call it as major depressive disorder. So, welcome, guys, again. Now I'm depression, and I'm going to go through these symptoms again, which you can diagnose me with depression. Then you need at least five of the following, with at least one of the first two. Intense sadness. Sadness is common, sadness is normal. If I failed in my exam, I will be sad. If someone broke up with me, I will be sad. But this sadness is different. It does not need a reason. It is constantly there, and even if whatever you do, you still don't feel happy. It stays at least for 2 weeks consecutively. To diagnose depression, you need 2 weeks of all of these things at least regularly. Loss of interest in previously pleasurable activities. Previously, you used to enjoy playing cricket, used to like talking with your friends. Now You don't like any of them. You're absolutely dull. You don't want to talk with anyone and you prefer staying alone. You don't have energy in your body. You cannot walk. You cannot play with friends. You cannot talk with anyone. You're just on the bed lying down. So, out of these first three, you need at least one to diagnose major depressive disorder. Now, beyond this, there are these other additional features where you can have a disturbed sleep. You either sleep more or you sleep less. You have a disturbed appetite where you either eat too much or you eat very less. You're very restless. You cannot feel comfortable in any one position. So you keep moving around, not like move a lot, but in your same position, you are very restless. In your workplace, you're not able to concentrate. You try your best to do everything, but you keep getting distracted. And yes, the worst of all, you start getting ideas of harming yourself and you might attempt suicide sometimes as well. To diagnose mania, there is a scale called as Young Mania Rating Scale, YMRS. So there are these 11 questions that we, as a doctor, as a psychiatrist, ask you and mark, and based on that rating that we get, the score, we diagnose you as mania. For depression, there is a scale called as HAMD, Hamilton Rating Scale for Depression, which contains 17 questions. Coming to the important part, that is management. Management has five parts to it. Medicines is the most important part, and medicines is included in two parts: acute, that is to control the immediate episode, and the continued treatment, that is the management, that is prophylactic, so that you don't get this episode again. So when we start with this treatment, we don't start for a week or 2 weeks, we start it for months together based on the improvement. There are these day treatment programs which provide support and counseling. Sometimes, because you're consuming drugs such as alcohol or cannabis, you can have these episodes as well. And in severe cases, sometimes we need to admit and treat the patient in the hospital. Which type of medicines we use for bipolar disorder? Mood stabilizers are the most important one. As you could understand, this is a mood problem. So we need to stabilize the mood. We don't want it either high, we don't want it neither low, we want it neutral. So mood stabilizers include, like I discussed in the few questions initially, lithium, divalprex, carbamazepine, and lamotrigine. Sometimes the aggression is too much, the irritation is too much, so we start with antipsychotics too. Antipsychotics are medication which help the person calm down. These are medicines that we start only initially and then we stop it. There are antidepressants which help the depression in the major depressive phase, which we start along with the mood stabilizer. And then an antidepressant antipsychotic combination is also available, which also acts like a mood stabilizer. And lastly, sometimes some anti anxiety medicines help for sleep and to reduce the nervousness and the restlessness that the patient is experiencing. FDA is the governing agent which controls the medications available in the market. So, FDA has approved these four medicines which I spoke of: divalprex, lithium, carbamazepine, and lamotrigine. These mood stabilizers are the most important ones, which we start in the beginning as well. And these are the ones which we maintain. A few of them have some side effects, but if given in the right direction, in the right dose, and we keep checking, then we don't see any side effects. Secondly, psychotherapy plays a huge role. For example, IPSRT, interpersonal social rhythm therapy, is one type of psychotherapy which helps regulating the sleep, the appetite, the mood, and thus maintaining the person's regularity and allowing the person to not go into the high or the low. Cognitive behavioral therapy is one more form of therapy which is again very helpful and something that we again utilize very regularly to manage bipolar disorder, because a person needs to understand their thoughts to make sure that it doesn't either go high or low. So medicines and therapy together help the person get better very quickly. Thank you everyone. And that is my Instagram ID, Psychiatrist Speaks, where you can follow and find some interesting facts more on psychiatry related things. Thank you, and I welcome the floor for questions now.
Thank you so much, sir, for the comprehensive talk and for such wonderful insights that you have shared on such an important day. We have received few questions, and I would like to put it across to you. If you can just please turn on your camera.
Yes.
Yeah. So we have received few questions, and I would like to put it across to you. The first question is, what are the risk factors for the development of bipolar disorder type 1?
So, classically, the most important thing that we usually say is substances. Substances are one thing that I say is something that is in your control. If you don't take any alcohol or unnecessary smoking, weed or anything, then you don't, have a chance of getting this bipolar significantly. Apart from that, there are certain other things that people speak of, family history and genetics, but that is not in your control. And that is something that can cause this, but again, it does not lead to any changes in the treatment outcome. And apart from that, there are certain lifestyle changes for example, the pattern of your work and the kind of life that you're leading. If it's quite stress free, then it reduces the risk of you developing again bipolar type 1.
Thank you so much, sir, for answering the question. We'll move to the next question that we have received. And the next question is, how are differences in bipolar affective disorder phenotypes explained?
So, bipolar disorder is divided into mania and depression. Mania, in a milder version, is called as hypomania, and depression has three types: mild, moderate, severe. Bipolar again is divided into two parts: bipolar type 1 and bipolar type 2. Bipolar type 1 contains mania and depression. Bipolar type 2 contains hypomania and depression. And now there is one more type that people speak of, that is bipolar 3. That is a condition which is something that develops because of antidepressants given to patients. Sometimes, very rarely, when a person is already a known case of bipolar but has come for the first time with depression, and when we give antidepressants, this suddenly becomes into an episode of mania. And that's what we call it as a bipolar type 3.
Thank you, sir, for answering the question. We'll move to the next question. And the question is, what is the role of the major affective disorder, Loki, in the pathophysiology of bipolar affective disorder?
So that has been found to be one of the important factors in the causativeness also and in the prognosis part as well. But like I said, those are things that are not something that we control directly, so it does not affect in any manner of treatment, nor to be identified pre-handedly. We cannot make sure that this is the cause of major depressive disorder.
Thank you so much, sir. We'll move to the next question and the last question for today's session. And the question is, what is the role of genetics in the pathogenesis of bipolar affective disorder?
Like I already said, like we know, genetics is significant in understanding that if someone in the family has bipolar disorder, you have a partial chance of developing bipolar disorder too. But if you maintain a stress-free life and you make sure that you avoid any pointers where you know it can affect you, uh, for example, going for alcohol or cannabis or anything, then that genetics can be controlled in that manner, and you will not develop a bipolar disorder with a very huge probability.
Thank you, sir. Thank you for answering all the questions and for such wonderful insights upon the topic on such an important and precious day that you have shared in. So, thank you for such wonderful insights and for your valuable time. With this and with all your last comments, sir, we can conclude the session here for today. Until next time.
Thank you everyone for attending today's talk, and take care of yourself. All of these conditions are preventable if you avoid taking too much of stress in any manner. And always feel free to consult a psychiatrist or a psychologist whenever you feel that there is a problem that you cannot understand. Thank you and have a great day ahead, everyone.
Thank you. Thank you so much, sir. We are